My name is Corey Woodward. I am a third-year Masters of Social Work student at East Carolina University. Today's video will be discussing suicide. Suicide is often seen as a taboo subject and may be difficult to talk about or treat even as a clinician. Before I get started, I would like to ask you to be mindful of your emotions during this presentation. Many of us have been touched in some way by a completed suicide or suicidal ideations or behaviors. This is a heavy subject that may bring up negative feelings for you. If this is happening, please stop the video or excuse yourself to process your feelings and determine if you should continue with this presentation. If someone is available, please let them know you are okay or if you need additional assistance. I would like to provide everyone with access to the National Suicide Hotline at this time. That number is 1-800-273-8255. The Suicide Prevention Lifeline website is suicidepreventionlifeline.org. This offers a chat option, languages other than English, and services for those who are deaf or hard of hearing. In this video, you will learn what suicide is, the prevalence of suicide on the state, national, and international levels, the impacts of suicide, how to identify symptoms of suicidal ideations and behaviors, and strategies for suicide prevention. This video provides a lot of information. These resources will be available at the end of the video. The Centers for Disease Control defines suicide as a death caused by self-directed injurious behavior with any intent to die as a result of the behavior. As reported by the World Health Organization in 2014, approximately 1 million people die each year by suicide. According to the American Foundation for Suicide Prevention, suicide is the 10th leading cause of death in the United States. Each year, 44,193 Americans die by suicide. For every suicide, there is 25 attempts. Suicide costs the United States $51 billion annually. On average, there are 121 suicides per day. The rate of suicide is highest in middle-aged white men in particular. American Indians have the highest suicide rate, followed by whites, then Hispanics, Asians, Pacific Islanders, and African Americans. For North Carolina specifically, one person dies from suicide every 6 hours. Suicide is the 11th leading cause of death overall in North Carolina. Suicide costs North Carolina a total of $1,358,735,000 of combined lifetime medical and work loss costs. This is an average of $1,157,355 per suicide death. North Carolina ranks 36 in the nation for deaths by suicide. The underreporting of suicide and suicidal behaviors is a significant problem for research, education, and prevention. While many countries gather data related to suicide, these numbers are not accurate. It has been known for more than 200 years that suicide deaths and suicidal behaviors have been underreported. In the latter 1900s, it was estimated that in the United States, 30% of suicides were not reported. England reports a similar rate, and in Ireland the rate was 100%. There are many reasons suicides are underreported. Suicide may not be reported due to the stigma associated with completing suicide. Legal, religious, and political pressures, life-sustaining medication was not accepted, self-starvation, the death is a result of an assisted suicide, the suicide method. For instance, if someone decided to take their life by driving their car off a mountain, this may be reported as an accident instead of a suicide. A person is recorded as missing. Financial, because often suicides negate life insurance policies. Suspicious circumstances, such as a fall. Changes in coding from ICD-9 to ICD-10, and a lack of standardized certification processes. There are measures being taken to improve the data collection in regards to suicide. These efforts include adopting a standard definition of suicide, timely collection of data and entry into a central data bank, and well-defined procedures and trainings for those responsible for death certification. The Centers for Disease Control defines suicide as a death caused by self-directed injurious behavior with any intent to die as a result of the behavior. The DSM-5 defines a suicide attempt as a behavior that the individual has undertaken with at least some intent to die. There are more DSM-5 diagnoses with suicidal risk than not. Because there is no help for a completed suicide, we need to focus on symptom recognition and prevention. Prevention happens when we reduce a person's risk factors and increase their protective factors. How do we prepare ourselves as clinicians to be able to determine if someone is at risk for suicide? It is paramount we always remain aware that anyone may be contemplating suicide, and we need to assess for this at each interaction. Suicide happens across all locations, races, religions, incomes, sex, sexual orientation, mental health, medical health, and any other demographic area. Knowing this, we also need to be able to recognize those most likely to suicide. According to the CDC, men are 4 times more likely to commit suicide as women. Men are most likely to shoot themselves, while women are most likely to poison themselves. This alone can begin to inform you as a clinician. Men are not being reached or treated for suicidal ideations, and if they do express these ideas, their access to guns should be evaluated. For women, if they are considering suicide and they mention poisonings, they should be taken seriously as well. To continue with our discussion about who may be most at risk, clinicians need to consider the following risk factors provided by the CDC. If there is a family history of suicide, if there is a family history of child maltreatment, are there previous suicide attempts? Is there a history of mental disorders, particularly clinical depression, history of alcohol and substance use, feelings of hopelessness, cultural and religious beliefs, such as beliefs that suicide is a noble resolution of a personal dilemma, impulsive or aggressive tendencies, local epidemics of suicide, isolation or a feeling of being cut off from other people, barriers to accessing mental health treatment, loss, physical illness, easy access to lethal methods, an unwillingness to seek help because of the stigma attached to mental health and substance use disorders or to suicidal thoughts. Being aware of risk factors is important, but it is also important to understand protective factors. According to the CDC, we can promote the following protective factors to reduce the incidence of suicide. These protective factors are as listed. Effective clinical care for mental, physical, and substance use disorders, easy access to a variety of clinical interventions and support for help seeking, family and community support, support from ongoing medical and mental health care relationships, skills in problem solving, conflict resolution, and nonviolent ways of handling disputes, cultural and religious beliefs that discourage suicide and support instincts for self-preservation. When comparing risk factors to protective factors, the ratio is about 2 to 1, already stacking the deck against clinicians and society in general in the reduction of suicide. Suicide has far-reaching impacts. The most immediate impact is the loss of a life, but this is just the beginning. Suicide has a ripple effect extending from the close family and friends of the person who suicided to the financial cost absorbed by us all. Survivors of suicide are identified as the family members and friends of the person who suicided. According to the CDC, for every completed suicide, there are between 6 and 32 survivors. The National Suicide Prevention Lifeline estimates that 7% of us know someone who suicided within the last 12 months. These survivors are impacted by becoming more likely to themselves suicide. They deal with immense feelings of guilt, anger, abandonment, denial, helplessness, and shock. As clinicians, these may be the first impacts we react to. According to a study researching the experiences of survivors who engaged in individual therapy, 73% of suicide loss survivors have symptoms that would lead to a PTSD diagnosis, yet only 41% received such diagnoses. PTSD is common among survivors, and therapists need to be able to recognize these symptoms, be willing to diagnose it, and skilled at treating it. Individual therapy for suicide loss survivors is perceived as helpful by the majority of those who sought treatment. Time may be a factor in the benefit of therapy, as it has been found that those who seek treatment within the first 3 months of the loss find therapy more beneficial than those who seek treatment 3 months or more after the suicide event. The sex of the therapist may also play a role in the benefit of therapy. Those treated by a female practitioner reported more benefits from their therapy versus those with male practitioners. There is no prescriptive evidence yet discovered as to what should be offered to suicide loss survivors, but this research indicates the need for therapists trained in grief and/or traumatic loss and a willingness to diagnose PTSD when DSM-5 criteria are met, and for therapy to begin within 3 months of the suicide event. Continued research is needed to determine the exact benefits of individual therapy and how to bring that to suicide loss survivors, given the restraints of current funding models, which are time limiting. While current funding models do provide for a limited time of treatment, they may want to consider the cost of each suicide, which is $56.9 billion a year in combined medical and work loss costs. For each suicide, that's $1,287,534. Knowing the rates of suicide, risk factors, protective factors, and impacts of suicide, we as clinicians need to know how to screen for potential suicide behavior. There have been several tools developed to help clinicians identify those most likely to suicide. These include the Columbia Suicide Severity Rating Scale, also known as a CSSRS. This is a questionnaire used for suicide assessment. It is available in 114 country-specific languages and does not require mental health training to administer. Various professionals can administer this scale, including physicians, nurses, psychologists, social workers, peer counselors, coordinators, research assistants, high school students, teachers, and clergy. Another assessment method is the SAFE-T, which stands for Suicide Assessment 5-Step Evaluation and Triage. This was developed in collaboration with the Suicide Prevention Resource Center and Screening for Mental Health. Both of these screening tools, along with many other screening tools, can be found on the SAMHSA website. The PHQ-9 may be one of the more valuable screening tools as it is used in the primary care setting. This setting is often a person's first stop when they are not feeling well. Many clinicians will find themselves working in organizations that have already determined the appropriate screening and assessment tools for you to use, but it is important to know how to determine what screening tool is right for you if you are working independently or there are no guidelines available to you in your place of work. The Suicide Prevention Resource Center suggests clinicians ask themselves the following questions to determine what tool would work best for them. Is there evidence showing it will be effective with the population that you serve? Do you have the resources available to devote to the activity? Has the instrument been evaluated and found effective? Is there a cost associated with using the instrument? For what age group was the instrument developed? How long does it take to screen or assess an individual? Who will conduct the screening or assessment? Will it be a paraprofessional, healthcare professional, or mental health professional? Does using the instrument require training? If so, how expensive is this training and how many people will need to be trained? If you are planning to implement the screening, are you planning to screen universally or selectively? This video has provided a lot of information about suicide. We have responsibilities as clinicians to evaluate clients for any injurious behaviors each time we interact with them. It is important to be able to ask questions about suicide and suicidal thoughts and behaviors. It can be uncomfortable and may be necessary to practice this skill with a colleague. Everyone has the potential to suicide, whether it is those you meet in your professional or personal life. Be mindful of the risk factors such as clinical depression or the protective factors such as removing barriers to mental health services. Suicide takes lives and has devastating consequences for those left behind. Even if you are not directly impacted by suicide, we are all indirectly impacted through the financial cost. I would like to provide you with the Suicide Prevention Lifeline number once again. That number is 1-800-273-8255. And the Suicide Prevention Lifeline website is suicidepreventionlifeline.org. Thank you for watching this presentation.